Hello, Dr. Vollmer. Thank you for joining us for the Q&A session of the Ed Summit this year. We had quite a few questions turned in from listeners. Thank you, guys. We'll just get started with someone who has relapsing remitting MS, and they're wondering if they're destined to progress into secondary progressive MS. They don't feel as if their MS is advancing, but they don't know how to tell.
Good morning, Kelly. Well, the secondary progressive MS means that in addition to having acute relapse where people develop new symptoms that will increase over a matter of a few days to a week or so, peak and then get better, in secondary progressive disease, they also have a form of increasing disability that's gradual. So it's not something they notice on a day-to-day basis, but they notice it over months and certainly at the end of the year. The question of whether everybody with relapsing remitting MS is destined to move into secondary progressive disease is a good question, because the answer is no, not with today's therapies. Without having access to the treatments that we have, we would estimate 70 to 90% of people would ultimately end up in the secondary progressive phase. But now, if we can get treatment started early, and particularly with the treatments that we have, we don't expect any of our patients actually to move into secondary progressive disease. So it's a very preventable problem.
And can you speak about vaccines specifically with a DMT like Ocrevus? In these vaccines, we're talking about overseas travel, kind of the difference between the live vaccines and the dead vaccines, timing to get them with your infusions.
Okay, so with the immunosuppressive therapies, which include ocrelizumab, alemtuzumab, the Gilenya, Mayzent, the S1P receptor antagonist, cladribine. Those drugs increase the risk that if you were vaccinated with a live attenuated virus, which means it's a weakened version of the virus, but it still causes an infection, that infection could get out of control and cause more severe symptoms. The reason for Ocrevus being classified in that group is not because Ocrevus has caused that, but because the class of drugs that Ocrevus is in, which is the anti-CD20 monoclonal antibodies, was initially developed to treat lymphoma, rheumatoid arthritis, and lupus. And in that setting, a much higher dose than we use in MS was used, and it was combined with chemotherapies and steroids. In that setting, you could have a more severe infection from an attenuated live virus. But we actually don't see evidence of that kind of risk really with our patients. So if an attenuated live virus is needed, such as yellow fever, if you're going to someplace in Africa, then I think that it would be reasonable to go ahead and get it. The rest of the vaccines are either subunit vaccines or killed virus vaccines. In those cases, the issue with Ocrevus and related drugs is they might decrease the efficiency of the vaccine, so it may not work as well as it might for somebody who was not on the drug. But it still works in 70 to 80% of patients, so it's still worthwhile getting vaccinated.
One person heard you mention that Gilenya is not a drug that you would want to just stop, but they are interested in the DISCO MS study on discontinuing MS, wondering kind of what the study is showing and what the options are these days.
So the reason that we want to caution people of just stopping Gilenya suddenly in that class of medications is because there's a reported rebound in MS disease activity. It's not that common, but it is something that multiple centers like ours have seen. And so if you're going to take somebody off Gilenya, we would want to monitor them pretty closely for at least the next 6 months. The other drug where we see that kind of a rebound is actually Tysabri or natalizumab. And in that situation, it's a much more aggressive situation. But we can take people off the therapies, but they just need to be monitored more closely for the potential for rebound. The DISCO MS study is ongoing. It's fully enrolled. It will not end, though, until the first quarter of 2022. So we don't have any data from it at this point.
What are some of the common side effects of Ocrevus?
Well, the main side effects from Ocrevus are really the infusion reactions. They're not serious, but they consist of a scratchy throat, swelling of lips or tongue. It occurs in about 60% of people when they have the first dose of Ocrevus, but by the time they get to the third or fourth dose of Ocrevus, the risk is only about 5 or 10%. It's very rare that it is more than just a minor reaction that needs a little additional Benadryl or a steroid. The other side effects that we see are a syndrome called neutropenic fever, where the white blood cells go to 0 and patients have a low-grade fever. And then we usually have to treat them with a cytokine that stimulates the bone marrow to make white blood cells. So it's a treatable problem. It occurs maybe 1 out of 300, maybe 1 out of 500 people. And there's occasional cases of serum sickness where after about a week or two after the infusion, people will get a rash, low-grade fever, some muscle aches. And that's due to the fact that they develop antibodies to the drug, and the antibodies are binding to the drug and getting deposited in the walls of blood vessel, which causes inflammation. Again, it's treated with a low dose of steroids. And then the major risk that we really worry about is actually the drop in antibody levels. So Ocrevus and rituximab work by killing B lymphocytes. B lymphocytes make antibodies. So if you get a flu vaccine, it's the B lymphocytes that are responding to the flu vaccine to make the antibodies. And so it is possible for us to drop antibody levels. And in about 2% of our patients over 5 years, we can drop them to a level below 300 milligrams per deciliter, which is a critical level for us, because at that level, we know that there's a rise in serious infections. So it's not that common for people to drop their IgG levels. They do drop IgM levels, which is another type of antibody, but that's not associated with a significant rise in infection. So it's something that we monitor for. We can treat it if we need to with IVIG by replacing the antibodies per person. But that's the most worrisome thing that we have with Ocrevus.
And we had another person who has tried Ocrevus. She's had some pretty terrible side effects and heard that physicians at other centers are holding infusions until their B cell levels are, reach a certain point. So not necessarily doing the every 6 months dosing. Do you have thoughts on that?
Well, we've also considered that, particularly because we've had the drugs out long enough now that long-term therapy is resulting in a drop in antibody levels in some patients. However, there is data from the original studies with Ocrevus that suggested that larger patients had more progression than smaller patients, suggesting that maybe the dose that we're using is maybe not enough for some patients. So there is a consideration of doing a double dose study to see whether higher doses work better. But on the other hand, as I said, we have the problem of dropping antibody levels. So we have considered, and I actually have had some patients where we follow their B cell counts every 2 months. And then when the B cells begin to recover, then consider treating them at that time, particularly if they're having problems with the therapy. There are centers that do that more routinely than we do. But the problem is no one's done an actual study. So we don't really know whether that really prevents progression of multiple sclerosis. As the earlier question was about chance of moving to secondary progressive disease, you might have a higher chance of doing that by spreading the infusions out. So it's a potential future strategy, but it needs to be tested formally.
What DMTs are out there specifically for secondary progressive MS? And kind of just a general, there's so many options now. We've had so many approved in the last couple of years. What's the best DMT?
Okay. Well, based on real world observations where different groups, including our groups, have analyzed clinic data with patients who are actually using the medications, have basically confirmed that tisabr, natalizumab, ocrelizumab, rituximab are probably the most effective of the therapies that are reasonably safe. And so the Ocrevus in particular is approved for progressive forms and relapsing forms of multiple sclerosis. The other recent approval is siponimod or Mayzent, which is similar to Gilenya, which was specifically studied in secondary progressive disease and was shown to be effective, but it's approved for basically all active forms of MS. Also, biology continues to tell us that the biology of progressive disease is not really fundamentally different from relapse remitting disease. So we would expect the therapies, any of the therapies, to work proportionately in progressive disease as they do in relapsing disease. But unfortunately, in progressive disease, because of the loss of neurological reserve, the therapies have to be highly effective to show much benefit because of the effect of unmasking the effect of aging as well as subclinical disease activity. So in general, we would use an anti-CD20, which would be Ocrevus or rituximab as the first choice, and then the S1P receptor antagonists, which are Gilenya, Mayzent, and then ponesimod, which I don't remember its brand name, was just approved a couple of months ago. It's another version of Gilenya. So we have 5 therapies that are appropriate for secondary progressive forms of disease.
You guys have talked as a group a lot about neuroprotection and neural repair drugs that are hopefully on the horizon. Do you think these drugs will replace DMTs or be supplemental to DMTs?
In my view, they would be supplemental. They would be add-on therapies that we would use combined with other effective DMTs. In the past, the major effort for repair has been focused on remyelination. That's the antilingual molecules, biotin, other therapies. But I think the future is actually focusing on astrocytes, because astrocytes are the cells that support both neurons and oligodendrocytes, nerve cells, and then cells that make myelin. And they're the ones that actually can help those cells repair the brain. And we actually have quite a few different therapies that might work in that area. The Tecfidera, dimethylfumarate type therapies appear to work through astrocytes. Whether they induce repair or not, we don't know. Same is true for the Gilenya and the S1P receptor antagonists, Mayzent and ponesimod. But the ones that are really more interesting would be Metformin, which is a drug used in type 2 diabetes. In human observations, it's been noted that patients on Metformin who have a stroke tend to have less severe strokes and they tend to recover faster than people not on Metformin. A colleague of ours in London did a study in the animal model of MS and showed that rats that were given the EAE or MS-like disease treated with Metformin had remarkable recovery of function compared to the rats that didn't. And that's a therapy that's used in a couple million people already. So it's just a matter of demonstrating whether it actually is helpful for MS patients. And there are efforts to start those studies. Biotin was also studied recently as a potential repair therapy. And I know many people out there are taking biotin as a supplement, but they should know that the study did not show any benefit. And so at this time, we do not recommend taking biotin. Alpha-lipoic acid has also been suggested as a potential neuroprotective agent, but the clinical trial is just getting started, so we don't have enough data yet to really recommend that. There's a monoclonal antibody called alemtuzumab that induces, it blocks the signals that prevent the myelin-forming cells and neurons from making new branches and repairing. And that's in clinical trials. We're part of that study as well. So we have 2 active studies on repair. We expect to have a couple more later this year. So it's a very active area of research at this time. Don't have clear answers yet, but I think we will have over the next year or 2.
We had a couple follow-up questions to each of those categories. People want to know if we'll be involved in the metformin trials at the clinic.
We hope to. There are no active protocols in the world that we know of right at the moment. It's simply a matter of funding. The study design is pretty straightforward. It would be an add-on therapy that we would add on to whatever people are already on. And the initial study would be a biomarker study. We have the ability to measure molecules related to brain injury in the blood. And so it would be a fairly fast, small study to do a proof of concept type study. And if that was positive, then move into longer term phase 2, 3 type studies. But we have to get the funding for it. And it's a generic drug, so nobody owns intellectual property rights to it. And that makes it harder to raise the funds to do it because it basically be NIH or National Mental Society And NIH right now is a difficult resource for funding. National Society, I understand, has committed to funding such a study. Where it'll be done, I'm not quite sure.
As far as biotin and the alpha lipoic acid, some folks wanted confirmation that they should stop taking the high dose biotin, and then also wondering what a good level would be if you were just taking it for like skin and nails.
Well, in the study, the dose was 300 milligrams a day. The tablets that you buy over the counter tend to be 1 milligram or less. So in terms of taking for hair or nails, I don't know. I suppose over the counter is fine. Although many of the patients who take high dose biotin notice that they do tend to have faster growing fingernails and hair. Yes, at this time we would say if you're taking biotin as a potential neuroprotective reparative therapy for MS, then at this time you should probably stop that because the study was negative. It didn't show even a real suggestion that there was a benefit. It's not that the biotin is particularly dangerous. I mean, there are a few side effects, but the major problem with it is it interferes with a number of different blood tests, particularly related to thyroid function, but also other blood tests, because it interferes with the mechanism for detecting positivity in the assays. So if you want to take over-the-counter biotin, I think that's fine. But at this point, the data says that taking large doses for MS is of no benefit.
And is there any recommendations on the amount of alpha lipoic acid to consider taking?
Well, again, the over-the-counter doses are quite low, and the doses in the study are 100 milligrams 3 times a day. We don't know the safety of that long-term. That's why we do the studies, and we don't know whether it really helps. So at this point, I don't recommend people trying to take the dose of alpha lipoic acid that's being studied clinically unless they're going to be in a study and monitored appropriately.
So we've talked a lot at this Ed Summit about the different mechanisms of the various DMTs. Are you guys looking at combination therapy, multiple DMTs working at different angles, such as the approach used in HIV and oncology?
Well, generally no, but the reason is that we have very highly effective therapies now. As I said, most of our patients on Ocrevus or rituximab or Tisabra and natalizumab don't have evidence that they have active disease. On average, if we have 100 patients on any one of those 3 drugs, on average, as a group, they're improving in pretty much any symptom of MS you look at. Not everybody has the same level of improvement, but again, on average, the group is getting better over time, not worse. So the issue for us is not so much having more of an immunological effect. The issue is how do we induce more of a reparative effect in the therapy? So again, it's the earlier conversation about potentially adding on therapies that help the brain repair itself is the real future. I don't think it's combining therapies that we currently have.
So when testing new DMTs, we've had a number of studies come out lately. Why do they benchmark them against older DMTs such as Avonex? Why don't they benchmark them against some of the newer therapies?
It's a good question. The reason is that it's easier to beat Avonex than it is to beat the more modern therapies. So if you use a more highly effective therapy, such as some of the orals or even worse, Ocrevus, the problem is that you'd have to have a very, very, very large study to even show a modest benefit over it. And it's not likely that you're going to have a dramatic effect over what Ocrevus or rituximab or Gilenya or Mayzent can do, because they're pretty effective therapies. So it's just a matter of the reality that if a new drug is going to be tested by a company, that they want to be able to compare it against something that's acceptable as a therapy for patients, so the patients are not on placebo, because ethically it's not appropriate to take patients with active disease and put them on long-term placebo studies these days. So that's why they use the older therapies. Now, today, right now, I would say that the more common therapies to be compared against are going to be Albagio and Tecfidera. So the newest studies going on are active comparator studies using Albagio or Tecfidera as the control agent.
So over the last 20 or so years, many DMTs have come out and the treatment of MS has become a little more nuanced. Can MS be adequately managed by community general neurologists, or do you recommend a specialist?
Oh, I think they could be managed by an internal medicine specialist if they had the appropriate background and knowledge. Um, so it's not a matter of whether you're a general neurologist or a specialist, it's just a matter of your familiarity with the drugs, understanding the biology of the disease. So for example, in this last year, the anti-CD20s, which are rituximab and ocrelizumab, and now ofatumumab, which is likely to be approved any day, have now become the most commonly prescribed drugs. And the reason it took several years for that to happen was just physicians becoming comfortable with what the drug really does versus what they think it might do. Because again, it was primarily used for cancer and as part of a strong immunosuppressive therapy, the chemotherapy for rheumatoid arthritis and lupus. And in that situation, there are serious risks that are fairly common with its use. Now using it as a lower dose monotherapy, the safety is really pretty good. And it just took a while for physicians to become aware of that and really understand that. And so the issues with treating MS now, in addition to understanding the drugs and how they work, is also understanding the safety monitoring programs that you need to do to maximize safety for the patients. And but it's something any physician could learn to do if they wanted to do that.
On the subject of multivitamins, many patients with MS are already taking vitamin D. This particular person is taking 5,000 milligrams of vitamin D daily. And she's looking at a vitamin, just a general multivitamin high in vitamin C, zinc, and then another 5,000 milligrams of vitamin D. What are your thoughts on taking immune boosting